Thanks, Nick. This will be a slightly rough segue, I think, from the world of mechanisms and etiologies to really an area that I think, and speaking as an intensivist, I think we've been really lax and have not focused on the issue of recovery nearly enough. And it's become more and more apparent, particularly for many of the diseases that we treat, particularly sepsis. The majority of that develop acute kidney injury with sepsis already have injury at the molecular level when they present to medical attention. So even though they may not have manifest AKI in terms of creatinine in urine output, if you actually look by biomarkers or by other techniques, you will see that there's already injury going on in the kidney at the time the patient is presented to medical attention. And I would challenge us actually to think about situations that we're classically thinking about as more hospital-acquired AKI, for example, cardiac surgery. About how the injury is predictable and has occurred in the setting where we're observing the patient. And I would challenge that a little bit because the patients that often develop acute kidney injury in the setting of cardiac surgery are patients that have already received a dialode as part of their cardiac catheterization, sometimes just 24 hours before. They may be on receiving a balloon contrapulsation. They may have microemboli from ruptured from plaques in the aorta. They may have decreased myocardial function, and therefore cardiorenal syndrome. And so they're not as clear and as clean and as easy a population to think about as we're led to believe. This all has an impact in terms of thinking about the long-term outcomes of patients. And so if you think about how I'm going to prevent AKI, to what I'm going to do in the future, which is to modify the natural history so that patients don't progress to more severe AKI and the patients can have a reasonable recovery, you have to have a framework in order to understand. We don't even have a language, really, when it comes right down to it. We have this entity known as acute kidney injury, and we have this entity known as chronic kidney disease, and we have essentially 83 days in between, the 1 week and the 90 days, which is sort of vague about. And this is some data that we looked at a few years ago from a community-acquired pneumonia cohort. And you can see that that patients, first of all, in pneumonia, even outside the ICU, and the majority of these patients never made it to the ICU. They were 84% of these patients were just on a regular hospital floor, and yet the frequency of AKI is about 34% in this population. Importantly, these patients that develop severe AKI, and even in this case, milder AKI, the 1-year survival in these patients is significantly different from patients that don't develop acute kidney injury. And notice that there's a lot going on after the first 7 days in terms of progression, in terms of risk for mortality. We need to focus on what happens after the acute event as much as we're focusing on AKI. And Mink and others have really highlighted this of understanding the interplay between acute kidney injury and chronic kidney disease, and we're beginning to understand this much more as a spectrum rather than as separate entities. I frequently tease Mink that he's actually doubled my workload because I used to be able to attend, for example, the ASN and ignore all of the talks on chronic kidney disease because that wasn't anything that I paid attention to. And now I have to go to all of those talks and pay attention. Thank you for that, Nick. And he's highlighted the variety of different cellular mechanisms that are involved, and we're beginning to understand this at a much more detailed level. And it has significant effects that we still don't completely understand on outcomes related to things like cardiovascular disease. And it's not even clear that the way you get from AKI to cardiovascular disease is really through CKD. In other words, we understand if you have acute kidney injury, you don't recover, and you develop CKD, you're going to have an increased risk for cardiovascular disease. There should be some increased risk, although it's certainly much smaller. This is statistically significant here between patients that don't have any evidence of chronic kidney disease, but have sustained an episode of AKI and their downstream risk of cardiovascular events. And we don't really understand why this is true. These are patients that have had a history of disease versus those that haven't had pre-existing cardiovascular disease. And you can see that there's still a significant difference in the rates of cardiovascular disease, particularly in patients that have had some recovery. And this is a level of renal function that's above the threshold in many cases for chronic kidney disease. So just saying, well, their EGFR is better than 60 doesn't a risk for cardiovascular events. And you're not going to resuscitate yourself out of this. This is some data from the trial that we published on last year using early goal-directed therapy in patients with septic shock. And not only did the intervention not decrease the rates of acute kidney injury or improve their recovery, did recover renal function have a pretty good outcome. But those that don't have quite severe both short-term and long-term outcomes. And it may in fact be that even very mild changes in renal function are associated with an increased risk of mortality, and even smaller changes in renal function may be associated with increased risk for chronic renal disease, including end-stage renal disease. So we need to focus on recovery. We need to say, how do we get from where we are right now, where our focus is largely on and on chronic kidney disease as though they were two separate entities, but think about the entire transition of care. It involves, in many cases, multiple care providers. Intensivists don't follow patients after ICU discharge. Typically, nephrologists are often not involved in the acute care. And how do we, and then may in fact not even be involved in the care of patients who are destined to develop CKD, and how do we fix all of that? And so this is a major area that I think is in many cases just as nascent as acute renal failure. 16 years ago, when we assembled the first ADQI to try to deal with developing a common language, a common way of communicating with each other about acute kidney injury. So the Acute Disease Quality Initiative 16 was a meeting in San Diego and focused on persistent acute kidney injury, drug use and dosing in acute kidney disease, follow-up for acute replacement therapy and recovery. And I think it's important to focus on what we're telling our patients. When do we tell them when the episode of AKI is over? I don't know the answer to that. When can I restart the drugs, the arthritis drugs, the non-steroidals that I need to, get out of bed in the morning? When is it safe to do that after AKI? You know the answer to that? I don't know the answer to that. I don't know what to tell patients. When is follow-up needed? If the patient seems to recover renal function at hospital discharge, do I just pretend they didn't have it? Or do I say, no, I think we need to follow those patients more closely. What recommendations should we give? This is an area which is entirely unknown. And the KDIGO guideline tried to focus on this a little bit, and just by bridging this issue of, look, we certainly should not let these patients go 3 months and not have an evaluation for chronic kidney disease. But is that enough? It's a bit like of the Golden Gate Bridge about trying to provide some care for patients that they had this event. What are we going to do for these patients? Are we just going to wait and ask them to call us if they now have end-stage renal disease? And Andy Sue has shown here, I think, in this study that these patients are just lost to follow-up most of the time. Only about 11% of patients that had an episode of AKI were ever referred to after their event. So they're just lost to follow-up. What opportunities do we have that we've missed to manage these patients better? What do our patients tell us, by the way? This is some work that we've done as part of ongoing follow-up of these patients in a study that Nick and I have been doing over the last few years. This is just some testimonials from patients. A 35-year-old with sepsis, had ARDS, had AKI, was on renal replacement therapy for 6 days, And she told me, she said, I was never told that I had a kidney problem. I was never told. I have no idea what my kidney function is like now, and I've never seen a nephrologist as an outpatient. A 50-year-old who had a nephrectomy for renal cell CA. I presume that my remaining one kidney function is less than when I had two, but I don't know if that means anything. Who was supposed to tell me about this? I never saw a nephrologist, and my surgeon never said anything.
Okay.
So this is the situation out in the real world with real patients.
Okay.
So what we focused on in this ADQI was, first of all, this persistent AKI, because as many as 70% of patients who have stage 1 AKI recover within 48 hours of their event. As many as a third of patients who have even stage 2, stage 3 AKI recover rapidly. Those patients that don't, those patients with persistent AKI really require an additional attention and a re-evaluation of what we think the mechanisms of injury are, so that we're not missing modifiable exposures. So this is sort of a paradigm that sort of came up with biomarker assessment, functional assessment, understanding that patients can go through these different areas over time and require different assessment if they're not appearing to resolve their acute kidney injury early, and then therefore fall into this classification of persistent AKI. One of the other things we recognize is that recovery can be fleeting, and in point of fact, the most common pattern that we see in patients that have had acute kidney injury is a stuttering or relapsing course. And we really don't understand why this occurs. Is this just part of the natural history of acute kidney injury and our lack of ability to measure it well? Do patients who get volume resuscitation and seem to have an increase in urine output and a decrease in creatinine, is that really an improvement, or are we just diluting the creatinine and forcing the urine output up? Many of these patients will relapse and develop more severe acute kidney injury down the road. To be free of acute kidney injury by creatinine and urine output for about 72 hours to have any confidence that the episode of acute kidney injury has resolved. So just 24 hours of apparent resolution doesn't mean that you have, in fact, improved renal function. So the terminology is necessary, and we talked about how we really need to have a different set of words to describe all of this. Rapid reversal, to not call that recovery, because who knows if it's actual recovery, but to call rapid reversal resolution changes in renal function within 48 hours. Persistent AKI is when that doesn't happen. Sustained reversal requires at least 48, and I would actually say the data forces it more to about 72 hours of reversal before you can be assured that this is a sustained reversal. Recovery is probably something that after the acute kidney injury episode, after the acute illness has concluded, hospital discharge after day 7, after 14 days, is really a bit unclear. Probably many of these patients can't be assured that they've recovered until more like 30 days or 90 days after their acute episode. And then this brings up the idea that someone has had an episode of acute kidney injury. What do they have after 7 days? In the KD, suggested that the term acute kidney disease be used to bridge that gap between chronic acute kidney injury and chronic kidney disease. But what is that? How is that defined, and how is that operationalized? And I'll come back to that in a second. Well, I guess I'll cover it right now. So in the guideline, in the KDIGO guideline, we conceptualized it a little bit differently. We thought about it as something that was more pre-CKD. AKD was sort of pre-CKD. Sort of CKD that was before the 90-day cutoff. But in this ADQI, we really decided that what was more necessary, what was more needed, was to actually view this as an extension from acute kidney injury. Because this has implications for how we think about dosing of our drugs in the peri-AKI period. If you have an episode of AKI and you've only recovered renal function to the point that you have half the GFR that you had at baseline, you're not going to be back on the same doses of your activity drugs that are potentially nephrotoxic or are renally excreted. And there are a variety of, and I won't go through all of these, they'll be in the ADQI publication, but just a number of different considerations for nephrotoxic drug and renally clear drug treatment. So then we have rather than a CKD-centric definition of acute kidney disease, we have one that really bridges AKI. So if you have no resolution in your acute kidney, then you graph onto this criteria exactly where you were with the AKI. So, for example, if you had an episode of AKI in stage 2, and 3 weeks later, you still meet the criteria for stage 2 AKI. Now we're talking obviously about creatinine, because you're not going to have persistent oliguria for that long and still be off renal replacement therapy. But if you have stage 2 AKD, then we can put around that. We understand more about what that means. So I have now a patient who's had AKI, maybe they've had stage 3 AKI. 3 weeks later, they now have criteria for stage 2 AKI, except that it's now 3 weeks later. We don't call it AKI anymore. It's now stage 2 AKD. We even have a situation in which you have no apparent renal dysfunction, or you're below AKI stage 1, but your serum creatinine may not be back to normal. And that has an increase in long-term risk. It may even creatinine is all the way back to normal, but you still have biomarker or renal reserve abnormalities, that predisposes you to long-term outcomes. The goal, of course, is to be back to stage 0A. But even then, you may have a frail kidney, and you may manage those patients differently. Obviously, much of this is a research agenda for the future in terms of figuring out what to do for these patients. And so this is how that all sort of graphs together, this idea of what the follow-up should look like, who have had an episode of acute kidney injury, now have either complete or partial or no recovery from their episode of AKI, and by definition have acute kidney disease. And so within this 7 to 90 day window, this is the acute kidney disease window for diagnosis and management of their ongoing disease. And of course, the more severe, the earlier and the more frequent the follow-up should be. But the idea is that even patients that appear to have a good outcome, that appear to recover well, particularly if they had persistent AKI, may still have subclinical abnormalities that may predispose them to either subsequent events of AKI, or, as I showed you previously, this unexplained risk for cardiovascular disease. So in conclusion, approximately 2/3 of AKI is community acquired. That means that prevention is not going to be possible. Rapid reversal of AKI is common and should be the primary management goal. Relapses are common. Is this because the peri-AKI kidney is vulnerable to new injury, or is a stuttering clinical course just the norm for many patients? We really don't know. But we have now a robust research agenda. For AKI that does not reverse within 7 days, those patients are, by definition, have acute kidney disease, stages 1 through 3. Outcomes are poor for these patients, and special emphasis is needed to evaluate these patients for both their cardiovascular risk and their ongoing risk for eventual development of CKD. And with that, I thank you for